Thank you everyone for joining. This is a webinar to learn more about basics of lung ultrasound. We have the pleasure to have with us Dr. Nahreen Ahmed. She's from Philadelphia area, and she trained in New York City. And she has a fellowship in pulmonary and critical care, and also she's an expert in point-of-care ultrasound. She has a great experience doing large experience doing humanitarian work around the world. She has been with Global in several countries, including Bangladesh and Colombia, and she's currently the head of ultrasound department for Bridge to Health, and she's right now one of our frontline healthcare workers in Philadelphia. So it's my pleasure to introduce her and to receive this lecture from her, and it will be of great for all of you. Thank you so much.
Thank you, Denise, for that introduction, and I appreciate everybody being here, and I really hope that this lecture is helpful. Please, at the end, I would love to hear questions and ways that I can be more helpful for you based on what you're seeing on the ground. So what I'll cover, just because I'm not entirely sure of the background of everybody on the call, so I usually, when I do these lectures, I start off with the basics so that we're all on the same page. So what I'll be covering today, just one issue. There we go. So the objectives that I'll be covering today, it'll sort of be twofold. So I'll introduce lung ultrasound, its indications, review the proper equipment, which I'm not entirely sure what devices are available on the ground, but this should sort of cover the basics of that, as well as scanning techniques. So why is lung ultrasound helpful? It's immediately available at the bedside. It can be reproduced multiple times, unlike a chest x-ray or a CT scan, which require a lot more resources for that. It's very rapidly applicable, meaning if you see a problem, you can address it immediately, and it certainly is cost saving. Lung ultrasound has been studied for several years now. Point-of-care ultrasound, sort of to take a step back, I think many of you are emergency physicians, so you guys are the pioneers actually of point-of-care ultrasound. And me being in pulmonary and critical care, over the last decade, point-of-care has sort of become a part of our toolbox and now is becoming standard of care. As far as lung ultrasound itself, its diagnostic accuracy is actually superior to chest x-ray and very similar to CT scans for common lung pathologies. And it's especially so for those that are trained providers in lung ultrasound. It is one of the most easily teachable ultrasound exams, although has a lot of nuances, but I hope that I can cover some of the basics here for you. So what are the main applications? In basic lung ultrasound, the question that you're always answering, or rather in point-of-care ultrasound, you always want to ask a question, because that specific question is what you're trying to identify on the patient to help you understand what's wrong and what the pathology is. With lung ultrasound, usually the question is, why is the patient short of breath? So what are some of the pathologies that lung ultrasound can identify to help you answer that question? So the pathology that we can identify are interstitial processes. For instance, things like pulmonary edema, things like interstitial lung disease, pleural effusions can be identified, consolidation, such as what you would see with pneumonia, and pneumothorax. Pathology that cannot directly be identified by lung ultrasound are pulmonary embolus. So you cannot actually see necessarily a pulmonary embolus with lung ultrasound. You might be able to see evidence of infarct. And in the absence of any pathology from your lung ultrasound exam, it may suggest a diagnosis, but you won't necessarily see a direct finding. It's as if you would see a patient with no pathology on lung ultrasound is very similar to a patient who comes in short of breath, but with a normal x-ray. So if you think about it that way, it's an indirect way in how lung ultrasound can help you rule out several things to help you think about other diagnoses. You can't see obstructive lung pathology, such as a patient who is wheezing with COPD or asthma. And again, in the absence of any pathology on lung ultrasound, in conjunction with your physical exam, this is how this can be helpful. You can't directly see mediastinal and hilar adenopathy with lung ultrasound. And in reality, it's very challenging to differentiate between etiology of interstitial processes. And I say that with a caveat, without the physical exam and clinical history. So all of these things are identifiable, and you can identify the answer to the question of why the patient is short of breath with the following things. You see your patient and you get your clinical history, you get your exam, and then you have your adjunctive ultrasound. And with the combination of these three things, this should help you be able to identify the diagnosis for the patient, or at least the most likely differential. So I'll keep moving on. So what kind of equipment do we use in order to identify some of that pathology? So for those of you who already use ultrasound, you may be familiar with the fact that there are 3 different ultrasound probes, but I'm showing you 2 here. And really the main distinction between ultrasound probes are their frequency, low frequency and high frequency transducers. So we use the term probe and transducer sort of exchangeably. So low frequency transducers or probes can see structures with great depth. High frequency really focuses on structures that are superficial. So our low frequency probe, which usually ranges between 1 to 5 megahertz, which is what you're seeing in the top right picture, the general use for that is usually cardiac. We use that for lung. We use it for abdomen as well. And if you're limited where you don't have a curvilinear probe, which is the third probe that everybody's used to, which is also a low frequency probe, then you can use this probe for pretty much anything in the abdomen that you would utilize the curvilinear probe for. When you're limited, you kind of use what you have, and the depth for this is very similar to the depth for a curvilinear probe. For a curvilinear probe. So just something to keep in mind. The high frequency probe, which is what you see at the bottom here, which is probably what most of us are used to using for central venous lines, arterial lines. This is what you would use for superficial structures. And in particular with lung ultrasound, it helps us look at the pleura. That's the most superficial structure, and that's probably what it's most useful for. However, again, when we're limited, I would say if you had to choose one probe, you would choose the low frequency probe because you can see the pleura and you can see the lung pathology best with that. So as I said, the low frequency transducer is usually enough. The cardiac probe, which is the low frequency transducer, and a narrow footprint allow for better placement in that intercostal window. So remember, the basics of ultrasound. The thing to remember is ultrasound has everything to do with sound waves, and those sound waves being transmitted through different structures in the body. And something to remember is that bone deflects all of the sound waves. So this is why the comment of placement in the intercostal window is so important, because you want to actually be in between the rib spaces. And in order to do that, the probe itself has to have a narrow footprint. Now, the high frequency probe, of course, is better for pleural and lung sliding, and which we'll talk about a little bit more. And if you have that available, that's great. But of course, again, the low frequency probe is enough. So then how do we go from one, now we identified what tools we have or need, and now how do we actually scan our patient? What's the technique that we should use? So I have several other slide sets for sort of backtracking a little bit with basics of ultrasound. If folks need a little bit more background, that's completely fine. I'm going to send over some intro slides for physics of ultrasound, as well as some links for you guys if you need a little bit of a refresher going back a little bit more, because I understand that some people may have experience and some people may not, and that's completely fine. So just to kind of give you a little bit about ultrasound technique, we're typically looking at 2 different orientations, either a longitudinal orientation or a transverse orientation. Now, if you look here, if you see this probe has a dot, just like every other probe. I'm going to show you the one that I have. So I have a butterfly here. I don't know if you guys, can you guys actually see me as well?
Yes.
Okay, great. So, so here I'm holding a butterfly ultrasound probe. This is in the shape of a cardiac ultrasound probe. And what you're seeing here is that there are many lines and dots. The dots that are important are this dot here on the side, which is the orientation marker. And this is what you're seeing on the screen as well, which is what you're seeing as a different probe. And you see here this dot here, which is the same type of dot, which is the orientation marker, and that allows us to orient the actual plane of imaging. So when the transducer is in a longitudinal orientation, that means the dot is pointed towards the head. So in this image, you're seeing that the patient is laying flat on their back. The scanner is standing to the right of the patient, so on the patient's right side. And you're seeing that the dot here, so head is here, this is his neck, the dot is pointed towards his head. That creates a longitudinal axis, as if you can see, as if you can imagine a line being drawn from this dot that's going all the way down the patient to create your longitudinal axis, okay? And so when you do that, what shows up on the screen looks like this. Let's say, for instance, if you're looking at the base of the lung where the lung and the diaphragm meet, and here you're seeing the liver. And what you're seeing here is that there's a dot on the screen as well. This dot is supposed to match with this dot. So if this is longitudinal, that means that anything that's closer to the dot on the side of the dot, that's towards the head. So same thing here. Anything that's to the left of the dot is towards the head. Anything that's towards the right of the dot, which is going to correlate with below the dot here, right? So if you draw that line, everything above the dot is towards the head, everything below the dot is towards the feet. So anything to the left of the dot is towards the head, to the right of the dot is towards the feet. So if I'm looking here, I see the diaphragm, which is this white line, what we call hyperechoic, this white line here. Below that is the liver, which is a gray structure. And then above that is the lung. And so if I wanted to slide upward to see the lung and see more of the lung spaces, I would slide this probe up on the chest, and I would be moving up towards the head to see more spaces of the lung. Okay. So now that we know the orientation that we're using, how do we actually create a way in which we can see all lobes of the lung? Because you want to see as much lung tissue as possible to cover as much ground. So what we're seeing here is I'm showing you a diagram that basically reviews the international recommendations for point-of-care lung ultrasound, the consensus of how we break down lung zones. At the end of the day, the most important thing to keep in mind is it honestly doesn't matter how you break the lung zones down as long as you're covering all of the lungs. This is the easiest way to actually visualize this, and it's also the easiest way to communicate to your colleagues where you see the pathology. So if I say, okay, Dr. Smith, I see B lines in lung zone 1 on the right side and lung zone 2 on the left side, I am able to just communicate my findings. So that's why this is really helpful. Okay, and what we're seeing here is that you see two, and this is each hemithorax should be scanned in this way. And you're seeing 4 zones in the anterior lateral area. The first 2 zones are created by the parasternal line and the anterior axillary line that is bisected. And then you have these zones 3 and 4, which is in the axillary space, which is created by the anterior axillary line and posterior axillary line. And then you have your posterior spaces 5 and 6, which are especially incredibly important when you're looking for pneumonia. So what are some of the ultrasound findings that you can see with lung ultrasound? This is sort of the meat of the talk. And so what I want to I'm listing here for you the main findings that we're going to review. So we can find the pleural line, and you can see something called lung sliding, which is incredibly important to help differentiate between normal pleura or abnormal pleura. You can see A lines, B lines, effusions, and consolidations, and I'll go through what all of this means. So the basic view of what you get when you're looking at an intercostal space, and this is using the high-frequency probe, as you can see here, high frequency, it's under the vascular mode, and what you're seeing here is chest wall. So remember again, we're in longitudinal axis. That means that your probe is being put on the chest with the dot towards the head, and that means that what you're seeing on the left side of the screen is the rib, the rib that's the closest to the head, rib that's towards the feet, right? So if I wanted to slide upward superiorly to see intercostal spaces that are superior in the lung, I would slide up and I would want to see this exact image where you see the pleural line, which is this hyperechoic white line in between 2 ribs. Now remember what I said in the beginning, that bone does not absorbs sound waves. It reflects all of the sound waves. So what you're seeing here is actually a shadow because the sound waves hit the rib and they reflect back, and all you see is a shadow below that bone. And that's why you see this rib shadow. You see a rib shadow here and the intercostal space in between, and you see above, that's chest wall. And again, you see superior and inferior labeled here, and this is with the high frequency probe. So what does this look like dynamically? When you're using the high frequency probe, this is what it looks like. Okay, you're seeing your pleural line is now doing this movement, and this movement is what happens when the visceral and parietal pleura are moving against each other. It causes this shimmering at the pleural surface, and this is what we call lung sliding. This is when there's nothing in between the parietal and visceral pleura to obstruct that movement. So we see this in normal lungs, right? Now, in what scenarios would we see the absence of lung sliding? This is very important because the first thing people think about is, well, pneumothorax. While that's true, I put that at the bottom of this list because there are several other reasons why you might see absence of lung sliding, and that includes inflammatory adherences, pleurodesis, so literally anything that causes the parietal and visceral pleura to stick together, right? Loss of lung expansion, where you might see severe, significant atelectasis, or pneumo ex vacuo after you drain a pleural space with a pleural peel and the lung doesn't re-expand. You can see absence of lung sliding and apnea also, and then of course separated with by air or fluid in a pneumothorax, pneumonectomy, anything where the pleural space has been instrumented, you might also see absence of lung sliding. I'm going to really comment on this later as well, but you can see this with COVID patients also because COVID can cause a significant inflammatory response. It's usually peripheral based where you see the consolidations and ground glass, and that inflammation can actually falls under that inflammatory adherences, and you might see absence of lung sliding in patients with severe COVID. So what does this look like side by side? Now, I want you to also notice something here that I will mention at the last half of the presentation when I speak about COVID findings in lung ultrasound. I want you to notice that this pleural line is very straight, and I want you to notice the thickness of it and how there is no interruption in that pleural line. That is an example of a healthy pleural line, healthy pleura. Okay, so again, a pleural line that is nice and straight, that's not jagged, has no interruptions, and has this nice thin appearance to it. That is appearance of a nice healthy pleura. And the fact that it's shimmering, you're seeing that presence of lung sliding. Versus the picture to the right, the arrow is again pointing at the pleural line, but you're not seeing that shimmering, and this is the absence of lung sliding. Again, this can be in a patient with the right clinical context. It can be a patient with a pneumothorax. If they came in with trauma, et cetera, for some reason that you have that on your differential, it certainly can be. How do we confirm that? Since in reality, I'll go back to this picture for just a second. In reality, these images are quite crisp that you're seeing. You might not get that in your real life patients. Although these are real images, we always choose the best images for teaching purposes so that you can really see good examples of what we're talking about. But in reality, sometimes obese patients, you have a lot of chest wall to go through, or it's the way the patient is laying in the bed, sitting in the chair, you might not have the best view. So it's really important that you start to understand what creates a good view, as well as how you can confirm what you're looking at in some of these ultrasound findings. So when you're looking at the pleural line and you're not sure if you're seeing lung sliding, what you can use is Mmode. I'm not going to review necessarily all the things about Mmode. Mmode is a mode on the ultrasound that allows you to study the motion of a structure across a structure at a given point across a line that you create. So what you see here is when you tap Mmode on an ultrasound machine, and every machine kind of does this a little differently. When you click on the Mmode button on a machine, you'll see a line that drops down on your screen. You can move that line based on which machine it is. Sometimes it's a touchpad. Sometimes if you're using the butterfly, it's on the phone. You can use your finger. And you can drop that line exactly along the structure that you want to look at. In this scenario, you want to observe whether there is motion along the pleural line. So in this picture, that Mmode line is dropped in the center of the pleural line that you see here, that hyperechoic line. If you hit Mmode again, you'll see that this funny picture shows up, and we call this seashore sign. So this is what you see when the pleural line is moving, when there is lung sliding present. You see this beach-looking area and water here. The brightest line here is the pleural line, and below that is what you see when the pleural are moving against each other. You see this beach-looking sign here. And above here is chest wall, and chest wall is not moving, and so it looks like this. So alternatively, if you have a patient with absence of lung sliding, you'll see that everything below that pleural line looks like everything above it, meaning that it's kind of showing you that, well, nothing's moving. There's that absence of movement, absence of lung sliding, and you're seeing this, what we call barcode sign. So moving on, and to just kind of mention it here, lung ultrasound is really the study of artifacts. Without lung pathology, you cannot actually see anything that gives you an idea of what the diagnosis is. So pathology in the lungs is what creates these artifacts. And the reason for that is because sound waves don't really travel well with air. So the lungs, when they're fully normal, they're aerated, there's really not much to see there that causes scatter of the sound waves. So if you look here, when the next two artifacts that we're going to talk about are A lines and B lines. A lines are seen in a normal aerated lung, where there is no interstitial pathology. And what you see here is you have your ultrasound probe, which is sending out sound waves to normal lungs. Okay, so normal interlobular septa. And what's happening is you're seeing, the only thing you're seeing is actually reflective artifacts of the pleura reflecting across the lung tissue, okay, across the screen. So you're seeing your pleural line and you're seeing reflections of that pleural line, and that's all that is. That's telling you there's no pathology in the lung, that all you're seeing, all that's being transmitted is the reflection of the pleural line. Versus with B lines, which is more something that you see with some kind of pathology, you're seeing that here in this picture of the actual histopathology of the lung, you're seeing thickened interlobular septa. And remember again, those sound waves have to interact with something, and that something in the body has to have some amount of density to be able to absorb some sound waves and reflect back others. In order to do that, you have to have, again, some degree of density that can absorb and reflect. So those thickened interlobular septa are absorbing some sound waves, reflecting some back, and you're seeing these vertical lines, which are called B lines or lung comets. So what does that look like in reality? So again, remember, A lines are that reverberation from the probe to the pleura, and pleura is a very bright line. It's a very thick structure. And so what you're seeing is that there's reflections of the pleural line all the way down the screen. That indicates air-filled lungs, and you can see this in normal lungs, in COPD, because remember, COPD and asthma, that's obstructive airways. You're not necessarily seeing an interstitial process happening. You can see this in PE, remember, because we talked about in the beginning that PE, it's almost like a rule out. If you're seeing aerated lungs in both sides of the chest and posteriorly, then you don't have a reason to explain your dyspneic patient, and so you're thinking about PE. You can see this in pneumothorax, with the caveat being, you would see absence of lung sliding, but the presence of A lines, because remember, absence of lung sliding means you're seeing the pleura, but it's not moving. And because you're still seeing the pleura, it's still present, you will still have the reflection of the pleura down to the bottom of the screen. So again, I want to show you here A lines. These are your A lines, and they're reflections of the pleural line, which is the first line at the very top. Okay. Now, B lines are, as we mentioned in the previous 2 slides ago, are sound waves reflecting within a smaller space, such as the alveoli, and they look like this, what you see on the right. You see the pleural line, and this is all with the low frequency probe, by the way, and you can tell that by the footprint that you get here, that triangular looking footprint. And what you're seeing here is everything at the top is chest wall, okay? And then you see your pleural, your bright white pleural line that's shimmering, so you're seeing presence of lung sliding, and you're seeing these vertical lines that are coming from the pleura and going all the way to the bottom of the screen, okay? And these are what are called B lines. They move with the pleura. So if you have a pneumothorax, you are not going to see this. Okay, you are going to see this when you have presence of an interstitial process that's happening. Usually more than 3 B lines indicates pathology, and the differential is quite broad: alveolar fluid, pulmonary fibrosis, interstitial edema, atelectasis. So you might be thinking, well, how do I tell the difference between these? And that again goes back to one of my initial points, that with the physical exam and with the history, to really help as an adjunct. Because for instance, if you have a patient that comes in with lower extremity edema, they're short of breath, you take a look at their lungs and they have B lines all over their lungs, you might think, okay, this is probably most consistent with a person who is in heart failure. So again, B lines, these vertical lines, just to kind of reiterate that process. So how do we put this together? And I'm going to go into effusions and consolidations in a minute, but I just want to sort of help you organize this thought process. The Blue protocol was something that was originally designed to sort of help organize the thoughts when you see abnormal pathology. What do you do with it? How do you come up with an algorithm that you make sure you're covering all the things in lung ultrasound that can help with your diagnosis? So the first thing you think about is lung sliding. Is it absent or present? And you can kind of see it's a bit self-explanatory going down this tree. If it's present, you're looking at all of your six lung zones, and you're looking, are you seeing a B profile or an A profile? B profile, remember, is some alveolar interstitial process, and if you're seeing B profile, that means it's in both sides of the chest and in both of your hemithoraces, and you're thinking about pulmonary edema if that fits the patient. A profile, remember, that's when we saw no lung pathology in the chest, and all we were seeing are those horizontal reflections of the pleural line that are indicating aerated lungs with when lung sliding is present. And you're thinking about, what could that be if you're not seeing lung pathology? And that the next thing on here is venous analysis, because you might be thinking about PE. And if you would do your lower extremity DVT exam, if you know how to do that, and that's positive, that might increase your suspicion of PE. If you have free veins on a lower extremity DVT ultrasound, then you might be thinking about COPD or asthma. If you need to or haven't yet, you would listen to your patient's lungs to differentiate that. AB profile, so the reason it says lung sliding any is because, remember, we mentioned that with significant inflammatory adherences, you might see that the lung sliding is absent. And in that scenario, we might be thinking about a severe pneumonia. And C profile really refers to having a consolidation. I'll show you what that looks like in a minute. When your lung sliding is completely abolished, again, this could be pneumonia. And if you're seeing A lines, but the absence of lung sliding, this would be a patient with a pneumothorax. Okay, so again, this is a very simplified version of how to utilize what I'm teaching you and what I'm showing you. But because remember, there's so many other things that can fall outside of this tree, but it's really just to give you sort of a helpful place to start. So to review some of the things on the Blue protocol, bilateral A-line patterns with lung sliding is A profile. We kind of talked through that. B profile is bilateral B-line patterns with lung sliding, and we kind of talked through that. Again, everyone always thinks about pulmonary edema first. AB profile might be that on one side you see A lines and another you see B. Again, this is very common in patients with viral infections, viral pneumonias. Certainly with COVID, we're seeing more bilateral findings, but this is definitely something you might see early on. In zones 3 and 4, so remember, that's that axillary zone. The zone 3 is the top axillary zone. Zone 4 is sort of at the base. And this is where you would start to see that area in this bottom picture here with what was previously called the PLAPS, which stands for posterolateral alveolar pleural syndrome. That's where you see the diaphragm, the liver, or the spleen, depending on what side you are. That's below the diaphragm, and you see the base of the lung. Zone 4 is where it really depends. Zone 5, 6 is more base of the lung. Zone 4 could be middle lobe if you're on the right side, lower lobe if you're on the left side. Just keeping in mind your anatomy on a chest X-ray, it's very similar, right? So, so basically here, this area is incredibly important because pneumonias are often found at the base of the lung in that PLAPS zone. So zones 4, 5, and 6 is typically where we see that. Okay, so keep that in mind as we move forward. And zone 4 and zone 5, 6 is where you also might start to see some other pleural abnormalities, such as pleural effusion. Here, what you're seeing is the diaphragm, you're seeing a pleural effusion, which is this black area. So all fluid is seen as black on an ultrasound screen. And the reason for that is because anything that's fluid filled will absorb all of the sound waves and will not reflect anything back. So something that reflects everything back is very white and hyperechoic. A structure that reflects some sound waves, but not all, is somewhere on the grayscale. And structures or things in the body that absorb all the sound waves, that is something that looks black, or anechoic is what we say. And what you're seeing here is, remember, in lung ultrasound, if the lung is normal, it's aerated, and you're not really seeing the actual lung itself. However, here you're seeing a condensed lung. Either that's because there's pneumonia, or there's compressive atelectasis because of the fluid that's around. So what you're seeing, again, remember, the dot is to the left of the screen. The head, everything cephalad is to the left, everything towards the feet is here. So diaphragm, this is either liver or spleen, depending on what side of the body we're on, and we're seeing a condensed lung here. Okay, so again, to summarize pleural effusion findings, it's an anechoic dependent pattern, and you can, depending on if you're using Mmode, you can see a sinusoidal pattern with Mmode. And if you're utilizing your cardiac probe and you're looking at other zones, 1, 2, 3, it might look like this, where you see your pleural line, what looks like your pleural line. You see that anechoic space and what looks like a trapezoidal shape. Okay, so a little more about pleural effusions. Again, anechoic, that black space, you're seeing the tip of the lung sort of waving at you there, and you see your diaphragm much more clearly here, okay? Some other things that you might see when you have an effusion, you might see small dots like snow. Depending on where you live, if you've seen snow, it kind of looks like this, or static almost, and that's echogenic material within a pleural space, within the fluid in the pleural space. This has in the past suggested exudative effusion. However, there are still studies being done to correlate this, and that's more of a suggestion, not definitive. The performance of that visual characteristic is not quite known yet. But what plankton sign means is that it might be blood in there. Typically, if you're thinking about exudative effusions, it could be malignant effusion as well. It could be a hematocrit sign, where you have somebody with a hemothorax, and it may look like this as well. Okay. Again, here, this is a very complex pleural effusion. You're seeing your diaphragm, you're seeing your lung here, you're seeing what looks like a pleural line, but actually this is consolidated lung. Okay, this is consolidated lung. And you're seeing septation. So this is what an empyema looks like. One of the most important things with lung ultrasound is always know where you are in the body, especially in this particular zone of the body where you're looking at the diaphragm. What you're seeing here on the left-hand side is this is the kidney and this is the liver. And what you're seeing here is the hepatorenal recess. What's really important is that if you weren't entirely sure, you might think that this hepatorenal recess is actually the diaphragm, and you could imagine that calling accidentally what's above it a pneumonia, which is not true. Look to your right, sorry. If you look to the image on the right side here, you'll see the hepatorenal recess falls a little bit more inferior. You can fully identify the diaphragm here and notice that you have a pleural effusion with a complex septations and effusion that's noted here. I think what's very important is, if you're not sure what you're looking at, the kidney is always a great way to show you where you are. And so if you're not sure if you're looking at the diaphragm, slide all the way down, find your kidney, and slide all the way back up to make sure you know exactly where you are. Imagine trying to do a thoracentesis and not being able to identify the right space. You'll accidentally do a liver biopsy, and I don't think anybody will be happy about that. So next thing I'll talk about is lung consolidation. And after I finish up here, then I'm going to sort of shift over the conversation into COVID patients. So lung consolidation here, what you're seeing is these hyperechoic areas. So remember that when we're thinking about consolidation, you're thinking about a part of the lung that is just completely filled with pus, right? That's like what you're thinking about in lung consolidation that we're seeing in pneumonia. And we see air bronchograms as well. So what you're seeing here is these hyperechoic areas. You're seeing that the lung looks condensed. You're seeing a small effusion. You're seeing the diaphragm here, okay? So this is what we see when we see consolidation. So to shift over a little bit, so how do we then utilize all of these findings, and how do we utilize knowing that and understanding that and what we know about COVID-19 patients. So just to give you a little bit of background about how, the types of patients we're seeing, I apologize about the sirens in the background. I have been working mostly in COVID ICU units. I am also seeing patients on the general inpatient floor as well. And so I'm seeing a lot of different variations of lung ultrasound in COVID patients. So what I'm going to go through is basically what's been acquired by many of us that are doing lung ultrasound in the field. And how we're applying it is still a question, but I'm going to sort of go through that in depth. So lung ultrasound applications in COVID. So one of the first things that we've thought about is where exactly is lung ultrasound useful in COVID-19 patients? If we think about it this way, there are several different places where we're seeing COVID patients. If we start at the ER, then the question is, can we use this for potential triage? Can I take a patient who comes in and can I understand whether this is somebody that can go home, whether I need to send them to the ward or send them to the ICU, right? So that's a very important point of contention right now because it's not entirely clear. The other way that this is helpful is in diagnosis when testing or imaging is not available. I will say that there are scenarios in which we're seeing false negative testing happening in the hospitals. The sensitivity of the COVID testing that's available is still only 75%. So we are going to see false negatives, unfortunately. And in those patients where the suspicion is high, we are retesting. Certainly, there are parts of the world where that's not necessarily possible. And if that's the case, where testing is not necessarily possible, I can tell you one of our Ultrasound POCUS colleagues in Baltimore, Dr. Gigi Liu, is actually doing lung ultrasound on patients that are false negatives or that are thought to be highly suspicious of COVID, but their test was negative. And she is finding that that's very helpful to help increase the suspicion of whether the patient has COVID. Now, the last thing I didn't mention on here, but is still something that's quite controversial, is whether or not lung ultrasound can be used in the process of weaning patients from a ventilator. This is still a really controversial area because we just don't know the answer to that. One of the biggest things that really limits the lung ultrasound applications in COVID is just infectivity. So if you think about taking a device in the room, you have to have the capacity to clean it, because otherwise you are then taking that as a vector of transmission to the next patient. And if that next patient is not COVID positive, then you are putting them at risk of an exposure. So really, lung ultrasound is quite limited just by also that concept of transmission and vectors of disease. That said, I will kind of show you a little bit about what's been talked about so far. So PUI, I have probably mentioned that term a couple of times, is a person under investigation. It's just somebody that you think is potentially a COVID patient. And the way that the proposed triage for ultrasound has been the following. So thinking about your risk first, is the age greater than 60? Do they have cardiovascular disease? Is their D-dimer elevated, CRP elevated, LDH? Do they have lymphopenia? These are sort of high risk characteristics that we see. If their risk is low and their lung ultrasound is normal, you might say, okay, this is somebody I can observe at home. If their risk is low, but their lung ultrasound is abnormal, the DISPO becomes home versus hospital observation. Because what's the part that we're missing here? We're missing that aspect of hypoxemia. So if your patient has abnormal lung ultrasound, but has good saturation, both at rest and with some exertion, then that's somebody you could potentially watch at home, versus the person that has an abnormal lung ultrasound with hypoxia that you would certainly want to admit to the hospital or to a clinical area that then separates them from where they are. Intermediate to high risk patients with normal lung ultrasound, we still think about admitting those patients because those patients are where we see the biggest decompensation and deterioration, where they come in on room air. These are patients that we're seeing with hypertension, with diabetes. Those are the two biggest risk factors. Oh geez, I'm sorry. B, do you mind hanging on 1 second? This is embarrassing. The door just rang. I think it was a delivery. Just give me 1 second. All right, take a 2-minute break.
to invite our attendees to, if they have any questions thus far, to put them into the chat box. You can send them to all of the panelists and the attendees if you want. And that way, when Dr. Nahreen is finished, we can review some of these questions and get some answers for you, or some direction for follow-up. Also, it might be a great opportunity if somebody wants to take a break to get a glass of water, or anything that they else might need. We're so grateful to have this team here with us, and we hope that this information is proving useful. This is one of the first of what we hope will be, many trainings. So, Dr. Sienna, I definitely encourage you and your team to identify training or educational opportunities that might be available, or I'm sorry, that y'all might need, and then we can work with our team and our resources. Maybe it's mental health. First aid like we did for Bangladesh this morning, some sort of, POCUS training like this. But yeah, just definitely, put your questions in the chat. Let us know what other educational opportunities we can provide for you, and we'll make sure that Denise and our team follows up with y'all. All right, Dr. Nahreen, I was just inviting the attendees to put some questions in the chat, and also think about what other further educational opportunities their field team might benefit from. So the floor is all yours again.
Great. So sorry about that.
Yeah.
What was I saying? So as far as patients who are intermediate to high risk, these are the patients that we are seeing, and I can tell you firsthand, these are patients who usually are above the age of 60 to 65, depending on comorbidities. Also, certainly having any kind of pulmonary comorbidity puts them at higher risk for decompensation, but just age and the history of hypertension and diabetes are two of the biggest risk factors that we see. And these are patients who come in on room air, they look okay, and then within a day, they're escalating to 2 to 4 liters of oxygen, and then all of a sudden, they're just crashing completely. And this happens over the course of just several hours. They go from looking like they have a normal work of breathing to being hypoxic and tachypnic, and then are immediately intubated. So it's quite a traumatic thing to see for hospital staff, because we're just not used to seeing such rapid deterioration when a patient looks so well. And oftentimes that deterioration happens even before, if the chest X-ray in the beginning looks somewhat underwhelming, even still, those patients can have hypoxia that's almost out of proportion to what we're seeing. The nice thing is that, remember in the very beginning, I mentioned that lung ultrasound actually is more sensitive than chest X-ray. And so when the patients are getting X-rays, and what we're seeing is that we are seeing more with the lung ultrasound, things like B lines, which really represent ground glass, that you get can kind of help you identify things that may not be visible on an X-ray, certainly visible on a CT, but not on an X-ray. Patients with intermediate to high risk with an abnormal lung ultrasound should be considered to go to the ICU, just based on what they look like as well, of course. These are patients who are tachypnic, who are upwards of 6 liters of oxygen is usually where we kind of start to think about putting these patients in the ICU. So just a way to think about how to triage patients. So how do we then take what we know about COVID patients and help us use that information to identify how we can continue to apply lung ultrasound? So this slide is a little busy, but I really want to focus your attention on the fact. So these are findings on chest CT in 121 COVID patients. What's really important is to look at the very top. It says ground glass opacities and consolidation. And what you'll see is that the majority of these patients have either ground glass or consolidation. And so the importance of that is you're seeing these two different processes that are happening. And a lot of times it has to do with the severity of the disease or the course in the disease, and then the number of lobes affected. You'll see, again, this is usually bilateral. If you go down to the bottom of that list, bilateral lung disease is the most commonly seen thing here. Certainly more than 2 lobes is almost always affected. The frequency of lobe involvement, this is incredibly important. And I want to focus on this because this is why lung ultrasound in the posterior aspects is incredibly important in COVID patients, because if you look, right lower lobe, 65% of patients had affected lung there, and the left lower lobe, 63%. Of course, yes, it's scattered throughout both lungs, but the lower lobes are the primarily affected, and if you don't do that those posterior zones, you will 100% miss this. The next question everybody asks is, well, what if I can't turn the patient over? What if I'm unable to access their posterior lung zones? Kind of do the best that you can. If you have an extra set of hands in the room, you can help them have you log roll the patient a little bit to get a view of the base. But whatever you can do in the resources that you have to do that is the best thing to do to really understand the pathology of the patient. So to kind of show you what all of those findings actually look like, so you have two CT findings here, the one on the left, sort of in the earlier phase of disease in a younger patient, and what you see on the right side is a little bit later course of the disease, although you can also see this when a patient presents on the earlier side, depending on severity. And what you're seeing on the left is peripheral ground glass. What you're seeing on the right is more consolidative features. And both of these things look a little different on lung ultrasound, so this can be helpful. However, we're still, to be very transparent in the POCUS world, we're still really studying this to see how useful this is when we're taking care of patients on the floor. Does it matter that we're seeing ground glass versus consolidation? To some extent, it probably does. But the issue is that a lot of the data we're getting from the Italian folks too is that, this disease is so unpredictable. And even if we're seeing ground glass and the equivalent of that, meaning confluence of B lines on the lung ultrasound versus consolidation, that doesn't necessarily mean that the patient's going to crash. Versus if you're only seeing ground glass, that patient could crash just as easily as the patient with a combination of peripheral and consolidated features. So I think that that's a really important point, that the way the patient looks and their hypoxia has to be in conjunction with what you're finding. So lung ultrasound findings, to sort of summarize them for COVID-19 patients, I should really say, instead of thickened, I should call it a regular pleural line. There is some back and forth about whether the thickness of the pleural line really matters. It's more so the irregularity. So remember I showed you those images where the pleural line was very straight and very regular appearing. That is a normal pleural line, and a regular pleural line is something that is seen in COVID. It's also actually seen in RSV and influenza. So what you're seeing here is a list of findings for actually patients with any kind of viral pneumonia. I would say the biggest thing that we're seeing that's most consistent with COVID is absence of a pleural effusion, although there are some cases that go against that. But for the majority, there's an absence of pleural effusions. And again, the posterior lung fields really being the most important site to look. But for the most part, what you're seeing here is a list of findings that you could probably find in a patient who has any other viral pneumonia. Specifically studied are influenza and RSV for like bronchiolitis. And for any of you that see pediatric patients, this might be a very similar appearing list for you, because that's a lot of what a lot of where that's studied. Typically, when patients come in with a viral prodrome, we're not always throwing the ultrasound on them, and so that's why it's not as well known on the adult side, or rather, it's not as used on the adult side as it is in the pediatric side. So again, I want to remind you of the lung zones, and the reason I do that is because I want to show you some schematics of what people are using in real time. So what you're seeing here, so I showed you the lung zones, and usually everybody's next question is, well, how do I exactly operationalize scanning those lung zones? Or here's how you can do that. So the image on the left, again, just kind of shows you these lung zones, but in a more general manner. It kind of combines lung zone 1 and 2, 3 and 4. And the reason that the posterior lung zone looks like this is because this area is where the scapula is. And remember, again, we can't image below bone. And so this lung zone 5 and 6 is sort of this odd shape here, which is just because you're avoiding scanning over the scapula. So then what's usually recommended is almost in this snake-like pattern that you're just scanning through all of these lung zones to cover as much ground as possible. Okay, remember your dot is towards the head, and you're just scanning across each of those lung zones to get as much of a view of the lung tissue as you can. Okay, so again, this is lung zones 1 and 2, 3 and 4, and you're doing the same thing across all lung zones to get that image in your head of what you're seeing and what lung lobes are involved. Okay, so I want to show you, these are courtesy of some docs at Hopkins. Gigi Liu had sent these over to me. She's an incredible, if any of you follow any of the POCUS experts on Twitter, she is one of the more vocal ones. So she sent these over to me, and I just want to go through these a little bit. So what we're seeing here on this right posterior zone is you're seeing irregular pleura. Remember how we talked about before, that straight pleural line is a healthy pleura. This is a very unhealthy appearing pleura. We're seeing B lines, we're seeing some subpleural consolidation. So what that means is these hyperechoic areas that are below the pleura. Now, because in COVID, the CT scans all show you that all of that consolidation and those ground glass abnormalities are all sort of on the periphery. So you're really seeing that it is everything is subpleural and very close to the pleura. And again, on the right side, in the right zone, posterior zone 6, you are seeing this area of consolidation here as well in an abnormal pleura. Okay, and again, you're seeing some scattered B lines here coming from the pleura itself, and then you're seeing this consolidated area right here. And these are all COVID positive patients that Gigi had taken these lung ultrasound scans on. Again, here you're seeing a jagged or irregular pleura. You can almost barely see it because it's disrupted by all of this consolidation here. And the same thing on this side, you're seeing a jagged, disrupted pleura with all of this consolidation seen here. Okay, and these are in lung zones 5 and 6, so those posterior lung zones. Here's a patient where in lung zones 1 and 2 are being highlighted. And again, here you're seeing a very jagged pleura. I want you to remember what it looked like in the beginning, that nice thin pleura that's moving against each other. You're not seeing that here. You're seeing this jagged, sluggish pleura. You're seeing, this is what we call confluent B lines. That means that all these B lines, there's so many B lines, it just looks like a big white space. And that's called confluent B lines. You will see some areas of sparing. That does happen, as you will see on the chest CT as well. And again, here you're seeing confluent B lines, and this is bilateral. So again, to reiterate, irregular pleura, you're seeing bilateral confluent B lines, you're seeing subpleural consolidations, and these are the things that you're seeing in your COVID patients. And these patients, when they come in, remember, you have to also get a good history. So for the most part, many of these patients are coming in with cough, usually a dry cough. They're short of breath, fevers. They can be high-grade fevers. We are seeing patients with nausea, vomiting, and diarrhea also. There is a subset of GI symptoms that we're seeing in about, I think it's about 10 to 15% of patients. But again, the biggest thing that we're seeing is that cough, that fever, persistence of fever, an increased work of breathing, and that dyspnea really, those are the things that we're seeing that are somewhat concerning. Typically, that happens about 5 to 7 days after exposure with somebody who was COVID positive. Certainly, that might not be knowledge that they have, and that's what we're seeing now that community spread has happened. Most people have no idea where they were potentially exposed. Some people do, and that's helpful, but the usual thought is to treat everybody like they're COVID positive until we know, because the transmission from one person to the next there's so much infectivity, and that transmission is so easily happening that we need to be very careful and treat everybody as if they're positive until we know that they're not. The last patient that I'll show you, this was on the left side, zone 5, and you're seeing here again these B lines, this jagged pleura, these subpleural consolidations. These are all very classic pictures of patients with COVID. I'm going to end with just one last thing, which is basically just some practical issues. So anything that we do, we have to minimize our harm to the patient. And so one really big practical issue is disinfection. So please, please, please let us know how we can help organize this based on the supplies that you have and the type of device that you're using. But please remember to clean the device before and after you go in to see a patient with it. Make sure you're wearing proper PPE. These are all incredibly important ways to try and minimize the transmission. And you guys will all have access to these slides, and I will add a slide with a link to a bunch of other resources for you as well. But I just want to comment that disinfection is a huge, huge issue, and we have to be extremely careful with this. So this is just kind of a nice breakdown of how to disinfect. Other practical issues that are associated with disinfection: if you don't have the hydrogen peroxide or bleach wipes that are typically available in most US hospitals, you can certainly prepare things like a bleach solution by just mixing 5 tablespoons with water, 4 with a quart of water, just depending on what the resources are. And we're seeing a lot of this being done in community hospitals if they're running out of the detergent that's being used to clean. For electronics, usually alcohol-based wipes are okay, anything that's at least 70% alcohol, and I would recommend drying the surfaces as quickly as possible to avoid the pooling of liquids that can actually cause some problem with the device itself. And specifically, that's probably most relevant to the Butterfly or the iVis or the Lumify if you're using any of those devices. So I'll just stop here. This is my last slide. It's a summary slide, really, and I'll kind of just leave this up as we talk a little bit more. And this was from so Twitter is a vast resource right now, but also I would say caution with anybody that's following up-to-date information from Twitter. I would always backtrack and look at the resources. So this is something I sort of vetted, which I thought was a really helpful summary of lung ultrasound in COVID patients. So, you know, the question of why bother with lung ultrasound, we kind of mentioned this: higher sensitivity than X-ray. The findings do correlate with CT scans pretty well. It can be performed pretty rapidly at the bedside. And then this question of risk stratification, that's still an ongoing question, but I think that there is some merit to that. And then again, a review of the lung ultrasound versus CT findings: that thickened pleura that you would see on a CT and lung ultrasound, you see that jagged pleural line. Ground glass will look like focal and multifocal and confluent V lines, and consolidation will look like what I talked about, those hyperechoic areas, those chunks of white areas in the lung, or subpleural, those small areas, small little white dots below the pleura that move or shimmer as a patient breathes, and those are the air bronchograms. And typically you have more than 2 lobes affected, and pleural effusions are often very rare. Again, how to scan is sort of listed here as well, what to look for, what to think about. So this is, I'm going to just highlight this for just a minute. Focused echo, so I didn't cover that here because that's a whole nother topic. But as we all know, COVID is associated with cardiac manifestations, specifically acute myocarditis. This could be seen with biventricular failure and pericardial effusion. So really keep an eye out, making sure getting a 12-lead EKG if there's any concern for that. And certainly focused echo plays a really big part in this. So when patients are hemodynamically unstable with COVID, we certainly look into that as well. And that's something I can cover in a separate talk. Echo is a little bit more nuanced and more difficult to pick up, but I'm happy to cover that as well in another talk if that's of interest to anybody. And then lastly, again, infection control is a very important part of what we're doing here. So I'll stop there, and I'm happy to take any questions. I think I went over just a little bit, yeah, I'll stop there for now and answer any questions or requests.
Amazing. Denise, do you want to direct the questions from the chat to Dr. Nahreen? I think Denise needs to unmute her microphone.
There she is.
Perfect.
Hello, everyone. I would thank you for sticking out for this lecture. I think we've learned a lot, Nahreen, even though we're not as expert as you are. This has been very informative. I would like to invite any of the attendees, if you have any questions, you would like not only questions about what we covered today, but also if you by listening to this lecture, if you think that there are other topics that you would like to have more information on, so we can do other webinars to talk more about it, let us know.
Awesome. Yeah, I think there are questions in the chat, Denise. I'm happy to read them out if you'd like, or if you want to.
I don't know why I don't see the question. Oh, sorry, the chat.
Here.
Okay, the chat. Okay, one question, the first question we have, if it helps, we have been using either articular diluted in 1 liter of water or Tristel 3-stage wipes to wipe them down. Can we clarify the difference in the Lung POCUS findings in pleural effusion versus pulmonary edema?
Okay, sure. So the question is lung POCUS findings in pleural effusion versus pulmonary edema. So let me go back. What I'm going to go back and show you is, this is a great question. So pleural effusion and pulmonary edema are a little different, right? So you can have bilateral pleural effusions in somebody who has pulmonary edema in the setting of cardiogenic or non-cardiogenic. But the two are different entities that may help you identify your etiology of your patient's shortness of breath. So what you're seeing here, I'll back up even more. Okay, so what you're seeing here is a pleural effusion. Okay, so a pleural effusion is the actual fluid that's around the lung. And you can see this on both sides. So if you have a patient who's coming in with pulmonary edema in heart failure, you might think about this patient having evidence of pulmonary edema, meaning fluid in the actual lung tissue itself, as well as fluid around the lung in the pleural space. So if you're looking at a pleural effusion, this is what you'll see. You'll see this black space, which is an anechoic space. Anechoic just means black, and that's the actual fluid. And this is the actual lung itself, which is probably compressed because of the fluid that's around it. What you're seeing here is the diaphragm. So pleural effusions will always be black like this. It will surround the lung. And usually the lung will sort of be flapping around in there. And you can see this bilaterally. This is just an example of what you would see on one side. Now, if you have a patient that has pulmonary edema, meaning actual extravascular lung water in the lung tissue itself, then what you would see is what we call B lines. Okay, and those B lines, which you're seeing here, these vertical lines, you would see that in all the different lobes of the lungs, and that is what we associate with pulmonary edema, because B lines are representative of any kind of interstitial process, alveolar interstitial process. So in pulmonary edema, that alveolar interstitial process that's happening is happening because of extravascular lung water or extra water in the alveolar or interstitium. And that appears as these vertical lines from the lung pleura that extend all the way down to the bottom of the screen. Again, the biggest question people ask is, well, how do I differentiate pulmonary edema from anything else that you see listed here? And that's a really tough question to answer, because it has to come from your clinical history and other exam findings that might be useful to help differentiate. Did that answer the question okay?
Thank you so much, Dr. Nahreen. Another question that we have is, they want to go over the signs of consolidation, ground glass in lungs.
Sure.
On the ultrasound.
Okay, great. And I see the question below that is actually relevant as well. So it's something about thickened and irregular pleura referring to C lines. So I'll start with signs of consolidation and ground glass. So ground glass will actually look I'm going to stay on this slide because ground glass will actually look like B lines. So ground glass will look like confluent B lines, which I will forward to the COVID slide. Okay, so this appearance that you see here in zone 5, you're seeing all of the above. You're seeing a irregular pleura, and you're seeing these confluent B lines. And those confluent B lines are what is associated with ground glass on the CT. So again, very challenging, right? That if you were to see this patient and you're worried, well, how can I tell the difference between pulmonary edema, which you also see B lines, versus is this a ground glass opacity that's associated with a viral infection? So there's one big thing that's going to answer that for you. Two big things, actually. The first one is you're seeing irregular pleura here. In pulmonary edema, your pleural line will always be a nice straight pleural line. You will not see this jaggedy pleural line that you see in patients with some kind of infectious process that's going on, especially in these viral infections. So you would see this irregular pleura with these B lines. That's more associated with that ground glass appearance. But I want to point out that if you have a patient with ground glass opacities, oftentimes on a CT, that too, the radiologist will say, well, clinical correlation advised, because this could also be pulmonary edema if it looks like it's gravity dependent, right? So the main thing here is knowing that those B lines with a jagged pleural line is what you typically see with COVID and those ground glass opacities, versus in pulmonary edema where you have a nice thin straight pleural line with B lines, and you see those B lines symmetrically everywhere. Whereas in COVID, you might be seeing those B lines asymmetrically everywhere. So maybe you see it in zone 5, zone 3, zone 2, kind of scattered all over, but not necessarily everywhere in every single zone. The next question was about consolidation. So there are two big types of consolidation. One that you're seeing here is what's called subpleural consolidation. It's right below the pleura. Pretty much everything, I guess, is technically right below the pleura, but this is consolidation, this area that you see here that's white, okay? You see this subpleural consolidation here. Here too, you see it at the base of the pleura. You see these small little blips in the pleural line. Those are all subpleural consolidations, versus the patient who has larger consolidations that you might be seeing at the lung base. I'm gonna just scroll back to answer that question. Okay. Whereas here, you're seeing these consolidations. This is where you're looking at the lung base, and you're seeing consolidations here, which are a little less subpleural, right? They're much more, they're much deeper in the lung. And you're seeing these areas of white shimmering. Those are areas of consolidation and air bronchograms. And as the patient breathes in and out, you're seeing that shimmering white kind of come and go, which is very consistent with the consolidation with air bronchograms. And really, the main thing to understand here is that this is a patient who's coming in probably with a fever and a cough, who sort of fits the typical picture of a patient with pneumonia as well. So that will also help you. And somebody asked the question about C lines. So it's actually C profile in the blue protocol refers to having a consolidation. So if you see something like this, that would be somebody with a C profile where you're seeing an area with consolidated lung. So it's A lines and B lines, and C is just for consolidation. C profile means that you're seeing an area of lung with consolidation. Any other questions we can address?
Ooh, Dr. Santa wants to know if you give hands-on training.
I do give hands-on training. I've never actually done that via webinar, but that's something we could potentially do. And certainly a lot of the video links that I will send you will have sort of a video where you can watch somebody being scanned, which is probably the closest you could get to seeing hands-on training. And so I think that's probably the closest we could do. The problem with doing hands-on training, so certainly if this whole pandemic wasn't happening, I'd be happy to be on the ground and giving hands-on training, since that's really what I love doing. But I think given the current situation, you're right to ask that question on maybe how we can think about doing hands-on training via webinar, where you're on the other side with your ultrasound and I can walk you through how to scan somebody. That's probably a way to do it. I think the next question was, I have no problem with you sharing this information. You'll get all of the slides and all of the links that will be helpful. And then the next question I saw was, is there a correlation between acute myocarditis and COVID? So yes, the answer to that, sort of at the end of my talk, I was sort of talking about that, how we do see acute myocarditis in these patients. We are seeing even patients that come in with STEMIs that end up having COVID. We are seeing a lot of stroke in these patients and a lot of vascular stuff as well. So as far as the acute myocarditis portion, that typically, I shouldn't say typically since these patients are so incredibly atypical and unpredictable sometimes, but we are often seeing it towards the end of their clinical course. However, some patients are just coming in with chest pain and acute myocarditis. You might see pleural effusion. You might see regional wall motion abnormalities. You might see biventricular failure. I agree it's a good idea to echo all COVID patients if you are able to perform echo knowledgeably, and I think that's where the biggest limitation is. If you can perform focused echo, I would highly suggest that those of you with that skill should do that with all of your COVID patients. I think it's incredibly important. It's especially important to re-examine them throughout their course if there's any change in their hemodynamics. A lot of what we're seeing is that in the beginning, maybe we'll see a little bit of, a trace pericardial effusion, but then as things progress, we are seeing patients in biventricular failure and cardiogenic shock. So we are seeing that in some of the more severe patients. So certainly serial echo exams when they're clinically warranted is very important as well. But I think that's a great point to make. I could absolutely do a session on echo. I think what would be really helpful for me to know is what background people have, so that because I don't want to repeat things that you might already know, and I'd like to focus on things that are the most useful to you guys. So if you guys have some background in echo, let me know. Then I'll kind of change the presentation for that to kind of start at a point where maybe if everybody has a little bit of background, then that's even better. If not, happy to start from the beginning. I have no problem with that. The one thing I would just caution everybody with is that with echo, if you have no experience from before, then all of a sudden starting to do echocardiogram without somebody, an expert in the field that can help out, can be somewhat tricky. And there's a lot of over-reading or underestimating what you're seeing or overcalling that can be quite problematic in the field. But I think it's still important to start with the basics. And of course, when it's possible to do hands-on training with echo, I would recommend that as soon as we can. The other thing I will mention, I'm not sure where people are seeing patients, but something I thought that was really interesting is there was a study that was published from out of Wuhan regarding how to manage some of these patients in the earlier phase. One of the things that we found to be incredibly helpful in these patients is actually awake proning or self-proning, which is actually asking the patient to lay on their belly. These are non-intubated patients. And those that are on room air, nasal cannula, on high flow, those are some of the things that we're using. Really having somebody that lays on their abdomen has prevented intubation in several patients. I've done this on ward patients and ICU patients. I had a patient that was laying on their abdomen for 12 hours a day. He was uncomfortable, but he did not need to get intubated, and I think we were able to prevent that. So I think some of these more conservative measures, when we're thinking about areas with patients that can be severe COVID patients, but maybe we don't have the resources to necessarily intubate them and things like that, we need to start getting somewhat creative. And certainly using that awake proning is a great concept. And then I'm happy to talk more about, I'm just not sure of what the COVID situation is on the ground in Greece or in some of the other disaster areas that we're in. But I'd love to kind of hear back from anybody that's on the ground to understand what they're seeing and how we can be helpful based on the sites themselves. So if that's useful at all, we can work together on that also. Dr. Maruf, that's a very nice comment. I look forward to that as well. I'm looking forward to being on the field to work with all of you, and hopefully sometime in the near future when all of this blows over, I hope.
All right. Well, if there are no other questions, we can wrap up. This presentation has been recorded, and we will share it along with other resources from Dr. Nahreen. Dr. Sienna, if you want to touch base with Denise after this, maybe do a needs assessment with your team and figure out what other trainings we can provide for you. We're happy to work with Dr. Nahreen as well as some of our other incredible volunteers. I want to say another enormous thank you, Dr. Nahreen, for giving us some time today on your Saturday, probably in the middle of 48-hour shifts in Philadelphia. So we're so grateful to be able to provide this as part of our COVID-19 digital response. Any other questions, after this, please feel free to direct them to Denise and we can get them answered. Denise, is there anything else you wanted to share before we closed out today?
No, nothing else. Thank you so much to you, B, for your support on making this webinar a reality, and of course, Dr. Nahreen Ahmed, your experience and all your knowledge and how you share that to the most in need is really grateful, and we are really thankful to have you.
I'm very appreciative to both of you and Med Global in general for creating these opportunities. So any way we can help, we're always here. So we'd love to keep talking and see different ways we can fill in some gaps wherever you guys need it. So just keep letting us know.
Yeah, I can imagine an opportunity where we instead used a regular Zoom meeting instead of the Zoom platform, so that the team on the ground in Greece could also have their cameras on if they wanted some more like direct feedback, so that you could see what they were doing. So that's definitely a possibility that I'm happy to make a reality.
That would be great. I'd be happy to do that. I think that would really, if we do, the sooner we do that, the better, because then I can actually, it will just really reinforce some of the concepts that we had here. And then I think that would be great. And I'm happy to schedule that at any time that everyone's free.
Amazing. Well, then I will leave that conversation to Dr. Sienna, Denise, and yourself, and Denise will tell me what I need to do technologically to make it happen. So I'm really looking forward to that. And if there's nothing else, I hope everyone has a wonderful as they can rest of their day, and we look forward to our next webinar.
Great. Same. Thanks, everyone.
Thank you all.
Stay safe.
Thank you, everyone.